One of the prerogatives of being president of the SSCI is being able to put together a presidential symposium. And for me, this is a topic that's been very near and dear to my heart, and we have two wonderful speakers. I'll introduce the first speaker, and then Dana Rizek will be introducing our second speaker. As I mentioned to the young people in the audience, I graduated from medical school in 1984. When I started medical school, HIV wasn't even known. And the first reports were coming out in the early 80s. And by the time I was a resident and then a fellow in pulmonary and critical care, we were in the full-blown epidemic. And for those people who were in medicine in the late 80s, they know exactly what I'm talking about. With the advent of antiretroviral therapy, it was just an amazing transformation. And we weren't watching young people die on a daily basis in our hospitals. But what was fascinating from a medical and scientific perspective is we began to see individuals who were living what appeared to be quite healthy lives on antiretroviral therapy, but now having more chronic complications that we had never seen before. And in the long, it's still known that people living with HIV, despite adequate retroviral therapy and viral suppression, have rates of pneumonia that are as high as 10 times the general population. And the chronic complications of kidney disease and other issues have really transformed what was obviously an acute and deadly illness into an illness that now still is living with chronic conditions. And so there's still many challenges ahead to solve the riddle for the more than 1 million people in the US and then 40 million or so living worldwide with HIV. So our first speaker is someone who's been very important for me professionally. Sushma Cribbs is a native of Boston, went to Boston University for college and medical school, and then much to the delight of everyone in Atlanta, decided to come to Emory for her internship and has been there ever since. She was an outstanding resident, she was a fellow in the program, and just as I was becoming division director 10 years ago, she and I sat and were discussing opportunities for her as she was joining the faculty and things to engage in. And at the time, my laboratory was working on animal models of HIV and identifying some of the mechanisms by which HIV may be impacting lung function. But what we were lacking is somebody who could really drive the clinical translational aspect of that research. Sushma seized that opportunity, and over the last decade, I was going to say is emerging on the national stage, but she's emerged. And Sushma has become well known for her outstanding clinical translational research in HIV in the lung. And it's very much my pleasure to introduce my young colleague and the first speaker in the symposium, Dr. Sushma Cribbs. Sushma?
Good morning, everybody. I'd like to thank David and Dana, Joan and Pamela and all the organizers for having me here today. It's a pleasure to talk about something so near and dear to my heart as well. So in the next 25 minutes or so, I'm hoping to give you an overview of HIV-related lung disease and where we are in 2019. I have nothing to disclose. So I'm going to start by providing you a brief overview of the epidemiology of HIV, and then we'll talk a little bit about some of the pulmonary immune alterations that occur in HIV, and touch briefly on some of the studies showing that the lung is a reservoir for HIV. We'll talk about some of the mechanisms of HIV-induced lung damage and some of the most common post-antiretroviral therapy era pulmonary complications. And I'll touch briefly on some implications for therapy. So as David alluded to, HIV continues to be a big problem worldwide. In 2017, the WHO estimated that there are approximately 37 million people living with HIV worldwide, the majority of which are in sub-Saharan Africa, where access to care and art is low. Of that 37 million, approximately 3.2 million are children as well. In that same year, there were approximately 1.8 million newly infected people with HIV and approximately 1 million AIDS-related deaths. Now, even here in the United States, HIV continues to be a big problem. The CDC estimates that there are approximately 1.2 million people living with HIV in the United States, of which approximately 40% are engaged in care, and even less are prescribed antiretroviral therapy. Now, even closer to home, here in the South, we have some of the highest rates of HIV diagnoses in the country. And in fact, by the end of 2015, approximately 46% of people living in the United States with HIV were here in the South. Now, since the first description of HIV/AIDS, the lung has been the site most frequently affected, and lung diseases were a leading cause of mortality in the HIV epidemic. Now, early on in the epidemic, people died from lung infections, such as bacterial pneumonia, PCP, and TB, and also AIDS-associated malignancies inside the lung, such as Kaposi sarcoma and non-Hodgkin's lymphoma. Now, the pulmonary complications of HIV study, PCHIS, was one of the first large multi-center studies to define the epidemiology of lung disease in HIV. It was a large cohort of approximately 1,300 HIV positive and HIV negative individuals, mostly men, reflecting the epidemic of the time. And what they found was that upper respiratory infections were the most frequent respiratory disorder in people living with HIV. And you can see here in this first graph that the episodes of bronchitis were much higher per 100 person year, even higher than that of PCP and bacterial pneumonia. They also found that lower respiratory tract infections tended to increase with decreasing CD4 cell counts. Now, non-infectious pulmonary complications were also found at this time, but they really took a back burner to the more highly morbid, opportunistic pneumonias that were killing people with HIV at that time. Still, using serial pulmonary function testing, this study found that people living with HIV did have an abnormal diffusion capacity for carbon monoxide, or an abnormal DLCO, and that the duration of HIV was an independent predictor of pulmonary function test decline. Now, the pulmonary complications of HIV tend to vary with and without antiretroviral therapy. For example, as you have cytomegalovirus and non-tuberculous mycobacterium tend to occur with more advanced immune suppression, whereas bacterial pneumonia can occur at any CD4 cell count. However, the risk of invasive disease tends to increase as the CD4 count declines. Now, non-infectious pulmonary complications can occur at any CD4 cell count. Complications such as COPD, pulmonary hypertension, interstitial lung disease, and lung cancer. So now I'd like to touch on some of the immune alterations that occur with HIV. Now, when a patient is first infected with HIV, there is a depletion of gut mucosal-associated effector CD4 T cells. As HIV progresses, if it remains untreated, you start to see a decline in CD4 T cell count, which is mostly due to a decline in naive and memory T cells. Now, in the lung, the same decrease in BAL CD4 T cells is not seen initially. And in fact, during the initial infection, you get a predominance of CD8 cytotoxic T lymphocytes. But as HIV progresses, if it remains untreated, you do see a decline in BAL CD4 T cells as well. And in fact, during the late infection, you get an increasing number of CD8 T suppressor cells. Now, with the initiation of HAART, you do get recovery of CD4 T cells, both systemically and in the lung as well. Now, although T lymphocytes are some of the most predominant cells infected by HIV, other cells are affected as well, including alveolar macrophages, B cells, and neutrophils also. Now, the impact of antiretroviral therapy on lung health is not well understood. Systemically, we know that ART decreases viral replication, increases CD4 count, and improves functionality. And in the lung, there do seem to be decreases in viral load, a decrease in alveolar lymphocytosis, which was that increase in CD8 T cells I mentioned earlier, and an improvement in cytokine dysregulation. But studies show that we can still detect HIV in lung cells even after 6 months of ART. And we all know that ART regimens can fail. They can fail due to a lack of adherence, due to IRIS, which is immune reconstitution inflammatory syndrome. They can fail due to increasing toxicity, and it's really unclear what the contribution of ART is to chronic lung disease in HIV. Now, HIV has been difficult to eradicate, and the difficulty really comes with long-term control of the infection, as the virus tends to rebound in peripheral blood when ART is discontinued. HIV integrates into the host DNA and can remain in a latent or transcriptionally inactive form for a long time. It can also persist in many cells. It can persist in T cells, dendritic cells, and macrophages as well. It can also be sequestered into tissue compartments, leading to tissue virus reservoirs. And these compartments can have differential immune responses and ARP penetrance, which can lead to drug resistance. But where does HIV hide? HIV exposure occurs at the mucosal surfaces, where it is transported to local lymph nodes by dendritic cells. Fusion of the dendritic cells with CD4 T cells can result in viral replication and activated lymphocytes. These activated T cells are then released into the bloodstream, where they are transported to various organs. Thank you. These organs can be the brain, thymus, spleen, CNS, and of course, the lung as well. So there is more and more evidence now emerging that the lung is a reservoir for HIV. Even back to the pre-ART era, HIV was detected in many intrapulmonary cells. HIV DNA can even be quantified in lung cells, including those from the monocyte and macrophage lineage. And studies have shown that the burden of HIV in the lungs can be even greater than that of peripheral blood. Other studies have shown distinct HIV variants in respiratory tissues, variations in genotype, and how the virus evolves as well. Now we know that HIV can infect specific lung cells. HIV can infect alveolar macrophages, which are the primary innate host immune defense cell in the lung. They're also the most plentiful cells in the lung and are resistant to apoptosis, so they can live for a long time. Some of the changes that have been described include impaired immune responses and impaired phagocytosis of infectious pathogens. HIV can also infect T cells in the lung. Approximately 5% of the total lymphocyte pool in the body is found in the alveolar space. And studies show that both CD4 and CD8 T cells in the lung are reservoirs for HIV. Some of the changes found here is a lymphocytic alveolitis due to that influx of CD8 T cells, and also changes in the cytokine balance, specifically a change in Th1 cytokines to Th2 cytokines, which is a change that's also critical for HIV disease progression. We also tend to see increased T cell exhaustion due to impaired proliferative responses, all of which can impact host immunity inside the lung. Now, although studies had shown early on that HIV was present in lung cells, many of these studies were done in patients who were not virally suppressed or were infected with pneumonia and other lung infections. Now, we showed a few years ago that HIV was present in alveolar macrophages even in otherwise healthy HIV-positive individuals with systemic viral suppression. HIV DNA and RNA was present in these macrophages, and the presence of HIV DNA within the macrophage was associated with impaired phagocytic function. So how does HIV cause lung damage? Well, there are a number of mechanisms of lung damage that are being studied right now. The persistence of HIV in the lung. I showed you that the lung is a reservoir for HIV, but it's really unknown how that causes impairments in immune function, how it might cause persistent lung damage down the road. Of course, the presence of the virus can also cause local pulmonary inflammation, increased pulmonary oxidative stress, and more studies are coming out now about the lung microbiome in HIV and how those changes might affect chronic lung disease down the road. And of course, there are a number of environmental influences as well, such as smoking, which can also exacerbate the effects of HIV. So in the next few slides, I'd just like to touch on these three mechanisms here. Now, the chronic immune activation in HIV can result in a dysregulated inflammatory response inside the lung. Although CD8 T cells in the lung are dysfunctional, they can still secrete cytokines in response to HIV-specific antigens. In fact, increased IL-6 is seen in the lungs of people living with HIV, and that has been associated with impaired lung function. We also see impaired TNF-alpha, both in the lungs of HIV transgenic rats, which is this graph here, and also asymptomatic people living with HIV. Chronic immune activation can also result in a release of matrix metalloproteinases, or MMPs. This is a family of endopeptidases released by alveolar macrophages with elastolytic activity that play key roles in extracellular matrix turnover. And our group has shown that the lungs of HIV transgenic rats have increased MMP9 in the lungs compared to wild type. Now, HIV can also directly promote oxidative stress in the lung. We have shown that in the lungs of people living with HIV, asymptomatic individuals, that there are significantly low levels of glutathione in the BAL. Now, glutathione is the primary antioxidant inside the alveolar space. We've also shown that there is increased NADPH oxidases, such as NOx1, 2, and 4, which are mediators of reactive oxygen species inside the lung. Studies have shown increase in TGF-beta. And our group has also shown that alveolar macrophages tend to have an inhibition of NRF2, which is a master transcription factor that activates the antioxidant response element. Now, another mechanism of HIV-induced lung damage that is being studied most recently are changes in the lung microbiome. So in 2009, the Lung HIV Microbiome Project was formed by NHLBI, and the project's goal was really to study the respiratory tract microbiome in HIV and non-HIV positive individuals. Now, there have been several studies that have come out of this consortium, and I just want to mention a few here. The first study to describe widespread colonization in asymptomatic HIV individuals was this one here, published in 2013. So using 16S ribosomal RNA sequencing, the authors here investigated bacterial gene sequences in HIV-positive individuals, both ART-treated and naive, and compared them to HIV-negative participants. And what they found was that 50% of the HIV-positive participants were colonized with Trophorema whippleyi in the lungs, which is the etiologic agent for Whipple's disease, and that the presence of HAART reduced abundance of this organism. The next study that came out after this one, a few years later, looked at the microbiome in oral wash and BAL, again in HIV-positive individuals, both ART-treated and naive, and compared them to HIV-negatives. And what they found is that there were significant differences in the microbiome between oral wash and BAL, but there were no differences in the BAL microbiome between the three groups. But the pattern of change in the microbiome in the ART-treated group was very similar to that of HIV-negative individuals. And finally, one of the more recent studies looked at the microbiome longitudinally, before ART, 1 month, 1 year, and 3 years after antiretroviral therapy. And they also looked at it in HIV-positive individuals with more advanced disease and compared them to HIV-negatives. And what they found was that HIV was associated with decreased alpha diversity in the microbiome, which is just a measure of within sample diversity, and increased beta diversity. There was also an increase in streptococcus that was found in the HIV-positive group. And the differences seemed to improve with ART, but there were still differences present even 3 years after antiretroviral therapy. Now, all of these studies are very important, but they're all very descriptive. And so it's really unclear now what the changes in the microbiome have with respect to clinical outcomes and pulmonary sequelae. So I'd like to switch gears a little bit now and talk about some of the most common pulmonary complications we're seeing now in people living with HIV. Now, as the incidence of opportunistic infections have declined, other infections, such as bacterial-acquired pneumonia and chronic lung diseases, are emerging as important contributors to morbidity and mortality. So next few slides, I'd like to touch on some of the more common ones, which is bacterial community-acquired pneumonia and COPD. Now, since HIV was first discovered, it has been known to increase the risk for pneumonia. But even now, despite antiretroviral therapy, people living with HIV remain susceptible to bacterial pneumonia. And in fact, as David alluded to, they have an increased risk, significantly increased risk compared to their non-HIV counterparts. And it remains a frequent cause of morbidity and mortality. In fact, bacterial pneumonia is the most frequent cause of pulmonary infections in HIV today. Now, the radiographic and clinical presentation is very similar, but again, the rate can be up to 25 times higher compared to an HIV-negative individual. There is an increased risk for invasive disease, and it can occur at any CD4 cell count. But the rate tends to increase as the CD4 count declines, and you can see that represented here by the orange bar, which represents the lower CD4 count. Now, HIV also increases the risk for COPD. One of the first studies conducted by Christina Carruthers in Seattle showed that in a cohort of HIV-positive veterans, that HIV was associated with approximately 50 to 60% increased risk for COPD, mostly seen in the older age group in that study. But she also found that the incidence of COPD was higher in people living with HIV, these are veterans again, really at any age group, even in those that were younger than 40 years old. So the important point here is that COPD can present at a much earlier age in HIV. People living with HIV who have COPD are much more likely to have acute exacerbations compared to non-HIV COPD patients. And time again, HIV has been shown to be an independent risk factor for low DLCO. Now, the pathogenesis of HIV-COPD is very complex. There's a number of factors that HIV is associated with that likely contribute to this: childhood illnesses, malnutrition, respiratory infections, changes in the microbiome, and of course, environmental factors as well, such as tobacco smoke and other pollutants. All of these things likely enhance or contribute to worsening immunocompromise, immune activation, inflammation, and oxidative stress that we already see in people living with HIV. So all of these things likely contribute to the premature chronic lung disease that we're seeing in these individuals. Now, in the lung HIV study, this was a large cohort, approximately 1,000 patients. They found a number of predictors of airway obstruction in this study. Factors such as age, current smoking, history of asthma, history of pneumocystis, and respiratory symptoms were all associated with an increased odds ratio for airway obstruction. What's interesting about this is these are all factors that can be assessed in an outpatient clinic. There have also been a number of biomarkers that have been studied as well, biomarkers that are related to various lung measures, such as decreased airflow, low FEV1 and a low FVC on spirometry, airflow obstruction, impaired gas exchange, again measured by DLCO, and the presence of emphysema by CT scan. These are markers related to inflammation, monocyte activation, endothelial dysfunction. And what I'd also like to point out here is that a high HIV viral load and a low CD4 count have also been associated with decreased airflow, and a low CD4 nadir has been associated with the presence of emphysema on CT scan. So investigating these mechanisms further, we can start to think more and more about how to target novel therapies to improve HIV-related lung disease. But there are a number of implications for therapy for HIV lung. Many of the drugs that have been tested in non-HIV individuals have not been tested in those people with HIV. There are definitely antiretroviral therapy interactions that have to be reviewed and thought about as we think about therapy. And of course, there are unique pathways in HIV pathogenesis that are not in non-HIV individuals. So in the next few slides, I'd just like to touch on some of the studies that have been done looking at specific therapies to improve lung immunity. Now, the SPARK trial was a randomized controlled trial investigating statins for pulmonary complications for chronic HIV. Now, the rationale behind this was that statins already reduce circulating inflammatory markers, markers that are also seen to be elevated in HIV, such as IL-6 and MMPs. And a recent study showed that there was a trend to improvement in the decline of FEV1% in non-HIV COPD. So what the study found was that there was a decrease, that the FEV1 decreased in the placebo group, but remained stable in the statin group after 6 months of statin therapy, and that the DLCO remained stable in the placebo group, but was increased in the statin group after 6 months of therapy. Now, this is very intriguing data, but I think we do need a larger trial. The sample size was quite small, and the absolute difference between the groups was not significant. Now, at Emory, we have been very interested in looking at the effects of antioxidants in improving lung immunity. And for the immune study, we hypothesized that 12 months of dietary zinc and acetylmethionine would enhance alveolar macrophage immune functions in immune non-responders. So for this study, we included immunological non-responders, which are people living with HIV who are on antiretroviral therapy and have viral suppression, but continue to have a CD4 count that is low, less than 350. We excluded a number of individuals, people who had liver, heart, renal, lung disease, those who were diabetics. And everybody in the study received dietary zinc and S-adenosylmethionine, or SAMe supplements, for 12 months. We did have a small cohort of patients that wanted to continue the therapy and went on for 24 months. Now, just a quick word on SAMe. SAMe is a cheap nutritional supplement, widely available in any local GNC, and has been known to increase glutathione levels. It's also been used in HIV before to treat depression and neurologic disorders. So we had about 20 patients who completed the treatment at 1 year and 11 subjects that went on for 2 years. And what I'd just like to point out here is that we did have a significant increase in mean CD4 count after 1 year of treatment, an increase that persisted to the 2-year mark in those 11 subjects. We also saw some improvement in immune activation profiles. We saw a decrease in T cell proliferation in the plasma of CD4 T cells, an effect that also persisted to 2 years, and a decrease in T cell activation of both CD4 and CD8 T cells after 2 years of treatment. We had a small group of subjects where we were able to measure alveolar macrophage function. Each one of these colored lines represents a different individual, and you can see that the majority of the individuals did have an improvement in their macrophage function after 1 year of treatment. So as we think more and more about HIV lung disease and where we are now, I do think we need more and more studies to understand the pathobiology of the lung in HIV. There's still much more work to be done. We know that the lung is a reservoir for HIV, but how it impacts lung immunity, how it puts patients at risk for lung infections and chronic lung disease is still not known. We also need to think about HIV and other comorbidities. As e-cigarettes rise and we are in our opiate epidemic, how these things affect lung immunity in people living with HIV who are on antiretroviral therapy is still unknown. And we need new lung biomarkers. We need new approaches to screening and diagnosis of these lung diseases in clinics as we see more and more patients living with HIV. And we need targeted therapies as well. There's more and more therapies arising for HIV, even to supplement antiretroviral therapy. So investigating the impact of these therapies on the lung, I think, will be very important. So with that, I would like to end and offer a very special thanks to our team at Emory, without whom none of this would be possible, and to all my collaborators at Emory and elsewhere. So with that, I'm happy to take questions. Thank you.